evening, everybody. At the outset, I would like to thank Dr. Radhakrishnan, Dr. Jayashree Su, Dr. Baljit Singh, and everybody at ICA for giving Tata Memorial Center this opportunity to present this webinar. I personally thank Dr. Sohan Solanki and Dr. Reshma from Mumbai, who are going to be a part of the panel discussion, and Dr. Sohan, who's going to moderate it. I thank Dr. Nishkarsh Gupta from All India Institute of Medical Sciences, New Delhi. Thank Dr. Jyoti Sharma from Bathinda and Dr. Indira Gurajala from Hyderabad. So let's kick it off. I'll be starting the webinar today with the talk on the impact of prehabilitation on patient outcome in hepatobiliary, colorectal, and upper GI cancer surgery. I head the department at Tata Cancer Center at New Chandigarh and Sangrur. This is the Punjab unit. The scope of this talk is, I'll talk very briefly about the introduction, definition, the limitation of all the data that's available, a little bit about the target patient population, what are the kind of surgeries where we try and implement prehabilitation, and what are the specific intervention and the outcomes. A bit of my talk will be brief because Dr. Nishkarsh will be talking about it in depth. Prehabilitation in literature actually goes back as far as 1946, where we saw in the Second World War a large number of men being rejected on account of their poor physical and mental health. And they had a program called Prehabilitation, Rehabilitation, and Revocation. And these recruits, over a period of 2 months, underwent educational, physical, and nutritional intervention. And of the 12,000 men who passed through these prehabilitation centers, they found that almost 85% of them improved both physically and mentally. Then in the 1980s, articles on prehabilitation started coming out, and this was actually in the sports medicine community. And this was primarily to prevent injury in athletes. We all are well aware that there's a significant decline in the functional capacity when someone undergoes a major surgery. So if preoperatively someone's functional capacity is already impaired, their outcomes will obviously be poor. And when we look at high-risk subgroup of patients, they account for just 12.5% of surgical admission, but account for almost 80% of post-operative deaths. So prehabilitation is a practice where you try and enhance a patient's functional capacity before surgery with the aim of improving the post-operative outcomes, like decreasing their length of stay, improving their post-operative pain, and improving their post-operative complications. By definition, it is a pre-operative process to enhance a patient's functional capacity and optimize the recovery from the stress of surgery and anesthesia. It is patient and procedure specific. Smoking or getting rid of any addiction has become an important aspect of prehabilitation. And once you decide that a patient is going to undergo surgery, till actually the time that the patient has the surgery is called a teachable moment, where the patient has to make an effort and bring about behavioral modifications. Multimodal approach is said to be better, and multidisciplinary and team approach is obviously works much better than one single department trying to modify a patient preoperatively. The target population obviously is the older age group and frail patients, because frailty, we are all aware, is associated with increased mortality, post-operative complication, increased hospital length of stay. They take more time to be discharged to an institutional care. There's functional decline, they have a low quality of life after various types of surgical procedures. And the surgical procedures where prehabilitation has been tried to be implemented are major GI surgeries, esophageal surgeries, gynecological surgery, urological procedures, thoracic surgery, and cardiac surgery. Sarcopenia and frailty is there in chronic liver disease. And this is primarily because of alteration in the protein turnover, hyperammonemia, where we find them that they are obtunded, they don't eat, there's energy disposal, there are hormonal changes, there's chronic inflammation. And sarcopenia, we are all well aware, is a skeletal muscle disorder where there's progressive and generalized loss of muscle mass, strength, and functional. There's physical disability and high rates of hospitalization and mortality. So chronic liver disease, we find frailty, we find sarcopenia, and there is ample literature in liver transplantation where we have seen that while the patients are on the wait list period, if we try and improve their muscle mass, we try and make sure that they get adequate nutrition, they tend to do better. So this can be easily extrapolated to any other form of surgery as well. Specific interventions are nutritional supplements, cessation of smoking or any addiction, physical exercise program where you identify the poor functional capacity and then you intervene to improve the physical functional. There's cognitive rehabilitation and stress reduction where you identify anxiety or depression and then you intervene to reduce the preoperative stress. So what is the impact or outcome that has been documented in literature? So I have picked up articles as far as 2017 and worked forward to 2023 and picked up some review articles and some original articles. Prehabilitation, which was published in 2017 in BJ Education, the key points of it was that it enhances an individual's functional capacity to withstand the stress of major surgery. Prehabilitation should always be multimodal and it should encompass the medical optimization, a preoperative physical exercise, nutrition support, and stress and anxiety reduction. And the outcome benefit is a reduced length of stay, less post-operative pain, fewer post-operative complications. But at that time, it was said that the evidence is fairly limited. And large-scale and high-quality studies were needed at that time. Before that, in 2016, the best practice for multimodal prehabilitation gave out exercise, nutritional support, mental support, and smoking as the key factors, the key steps in prehabilitation. And in 2019, this review article by Molinar et al. Was published in Innovative Surgical Science, where they said that it is a new frontier in preoperative care. And they concluded that multimodal prehabilitation before surgery increases the patient's physical, nutritional, and mental status. And there's growing evidence that it leads to a reduction of complication and faster recovery after surgery. It has been adopted in several new guidelines, but it is on the threshold of implementation. But the question remained at that point that should we offer our patients a chance to get fit for surgery now, or do we need to wait for more evidence? Now, in 2020, the systemic review by Daniels et al. In BJS Open was published, and they picked up 33 studies in which there were more than close to about 4,000 patients. And of these 9 studies, they purposely selected high-risk, frail, or older patients. And the 10 studies individually reported benefit in the complications rate. And they suggested that they benefit from a multimodal approach and improving the nutritional status. Now, the conclusion of this was that it was limited by the quality of the included study, and there was heterogeneity of interventions and outcome measures reported. And exercise, nutritional, and multimodal rehabilitation may reduce morbidity after abdominal surgery, but the data specific to older patients was sparse. Then 2021 in Esophagus, an article by Minella et al. Came out. This was a review article, and this specifically looked at esophageal adenocarcinomas, specifically because this disease is challenging, it's deadly. It affects the older patients. There's dysphagia, there's unintentional weight loss, muscle wasting, and persistent functional decline. And due to the aggressive nature of the disease and treatment, these patients were at increased risk for malnutrition, sarcopenia, frailty, and postoperative morbidity. And this adversely impacted the several determinants of health. And they concluded that, yes, clinicians do agree that we need to preserve the physical nutrition and the psychological status of a patient, and early nutritional support is universally accepted. And the intervention recommended to ensure nutritional adequacy or oppose the depletion of physiological reserves, and low preoperative fitness was consistently associated with an increased risk of postoperative pulmonary complications. 2021 and anesthesia, there was an original article by Kulop et al., and they used a trimodal prehabilitation method, and this was a single central randomized controlled trial of 149 patients, and they aimed to assess the impact of a 4-week trimodal prehabilitation program. And at the time of surgery, these patients they saw that the patients who were in the prehab group improved their 6-minute walk distance and inceptive spirometry compared to the control group, and had reduced anxiety score. These effects, however, did not translate into the improvement of post-operative morbidity, mortality, or reduction in the duration of the hospital stay. This large meta-analysis by Lambert et al. Was published in Annals of Surgery in 2021, with the objective to determine the impact of prehabilitation on the hospital length of stay, functional capacity, complications, and mortality after surgery in patients with hepatobiliary, colorectal, and upper GI surgery. And they picked up 15 eligible articles. And the main findings of the study was there was a statistically significant reduction in the hospital length of stay, with a mean reduction of 1.8 days with prehabilitation. Exercise prehabilitation, they saw, was dependent upon the nutritional status, and they suggested that the subsequent studies should follow up their patients for as much as 12 months. This article was, again, another review article which was published in 2022 by Jesse et al. With the aim to investigate the recent publications in the field of prehabilitation, and they picked up 13 studies to analyze. And the results of their review article was their prehab significantly improves postoperative complications rate, reduces the hospital length of stay, postoperative physical activity, reduces the treatment cost, pre-operative transfusion rates, antibiotic administrations, and the patient's adherence to post-operative recommendations. But on the other hand, there was no statistical impact was found on the prehab on the quality of life, psychological condition, readmission rate, or reoperation. Now, Curley et al. In 2022 published this original research article of 106 patients, and they used a 4-week trimodal prehab program combining physical therapy, nutritional support, and psychological preparation. And they saw that the 6-minute walking distance increased significantly after prehab. That means your functional capacity improved clinically, and it has been documented even previously that an increase of just about 20 meters has a positive impact on the outcome of colorectal surgery. Anxiety, depression, and several quality of life items also improved in this study. Again, in 2022, this was another research article by Waterland et al., which was published in Perioperative Medicine, in which 238 patients were screened, and 34% of the patients with poor fitness were finally recruited, and this was done by CPET. The prehab program was a 6-week program which comprised of aerobic and resistant exercise training, breathing exercise, and nutritional support. And the primary outcome was to see that whether they were able to recruit more than 70% of the patients, they were able to retain 85% of the patients, and intervention adherence was more than 70%. And the secondary outcome was to assess for improved preoperative functional status and health-related quality of life, and for postoperative complications. And this was an Australian study. And they saw that they really did not achieve their pre-specified targets. In fact, the adherence was hardly 12%, and because most of them wanted to do their exercises at home. So they pointed out that there needs the prehabilitation needs to be a refined process where when you implement it, it has to suit the needs of the local condition and the patient population so that there is compliance. 2022 saw this article, a review article being published in Cancer. And this was a comprehensive review where there were 21 articles that were dissected. I'll just talk about these 3 articles where I saw some form of impact on the physical status, where they saw there was a significant increase in the respiratory muscle strength. They saw an improvement in the 6-minute walk test. They saw an improvement on the VO2 and the VO2 peak, and there was increase in the quadriceps strength. However, there was no significant increase in the complications. They did see a lower hospital length of stay and better recovery, but there was no significant difference in the mortality between the 2 groups. Now, a negative review was also published in 2022. This was a Chinese study where they, a Chinese review where they picked up 15 studies, which had about 1,300 participants. And they said that there was no significant reduction in the number of the overall postoperative complications. There was no significant reduction in the length of stay. There was no significant reduction in the functional capacity either. And their view was that whether prehabilitation should really be recommended, and this really deserves a further consideration. Now, the last article that I could find was 23 in January in Annals of Surgical Oncology by Heel et al. And they wanted to assess the effect of a multimodal prehab program on the outcome of patients with they knew had a higher postoperative complication risk, and they used an emulated target trial design. Now, they had 251 patients, and with the intention to treat, and per-protocol analysis was performed to evaluate the effect of prehab compared with the usual care on the preoperative complications and the length of stay. Now, in the intent to treat analysis, they saw that the number needed to treat reduced by 1 or more complications in one person was 4.2. And compared with patients in the usual care groups, patients undergoing prehab had the 55% lower comprehensive complication score and a 33% reduction in the length of stay from 7 to 5 days, and a clinically relevant reduction of complication and length of stay after multimodal prehabilitation. So to summarize, prehabilitation, it can improve the recovery after treatment to reduce the severity of treatment-related complications that can actually cause significant disability. It can be offered as a single modality or multimodal, and multimodal has been stressed upon. Sick patients with comorbidities can benefit from prehabilitation. As the concept of prehabilitation appears more promising, there's some conflicting scientific evidence for its effectiveness. Several RCTs have been performed showing different effects of multimodal prehabilitation. So this shows a meaningful change in the postoperative functional walking capacity, shows a significant improvement in postoperative clinical outcomes, but there is really no significant effect on postoperative outcome. Thank you for a patient hearing. I hand over the session to the moderator. Thank you.
Yeah, thank you, Dr. Gauri Mitra. It was a good talk on the prehab part of HPV surgeries. So now for the next talk, I invite Dr. Nishkarsh Gupta, and he will be talking on the physiological and the pharmacological aspect and cognitive this prehab on a patient with the HPV disease for non-transplant GI surgeries. So Dr. Nishkarsh is a professor of oncology and palliative department in AIIMS, New Delhi. So welcome, Dr. Nishkarsh.
Thank you, Dr. Sohan, for the kind introduction. At the outset, I thank the team ICA and Dr. Sohan for giving this opportunity. So briefly, in next 16 minutes, I'll be taking you through a physiological and pharmacological optimization and cognitive rehabilitation of a patient with hepatobiliary disease posted for a non-transplant surgery. Okay. So I have no disclosures to disclose. So liver disease is a silent killer, as we know. And with time, there's a rise in patients with cirrhosis who may need a incidental surgery. And this is because we have advanced antiviral therapies. Then we have associated treatments aimed in improving the patients among cirrhosis. It is important to identify surgical risk factors which may lead to increased risk during the surgery. And the complications might include acute hepatic failure, infections, bleeding, poor wound healing, and renal dysfunction. Now, all of us know that liver has a good functional reserve because of dual blood supply, which is mainly portovenous and hepatoarterial. And it is important for synthesis of proteins, coagulation factors, glucose hemostasis, bilirubin excretion, drug metabolism, toxin removal, and many more such functions. And so the spectrum of liver disease may be an asymptomatic transaminitis to cirrhosis to an end-stage liver disease. And common causes, all of us know, can be varied from viral infections, drug abuse, alcohol abuse, autoimmune, metabolic disorders, and biliary tract disorders. Coming to a bit of pathophysiology. So we know the common causes of liver injury. So initially it might be starting as a chronic liver disease. There can be inflammation, cell death, proliferation, eventually leading to fibrosis, which subsequently leads to cirrhosis, and a prolonged cirrhosis may lead to malignancy. The important thing is that a cirrhotic liver may have a portal hypertension and extrahepatic complication, which may vary from a hepatorenal syndrome, ascites due to interplay of hepatorenal and cardiomyopathy, hepatic encephalopathy, which may lead to cognitive decline. I'll be discussing quite a bit of this in coming slides. Then can be a splanchnic vasodilatation, and there can be a hepatopulmonary syndrome. Coming to non-specific symptoms which patients might have, and this may be the initial symptoms which patients present to us with. It may be jaundice, weight loss, bleeding from the nose, vomiting of blood, fatigue, and stomach pain. So these are very non-specific symptoms, and patients do present to us in the OPD. Now we need to assess when the patient comes for a non-transplant surgery and patient has a liver disease. We need to assess the surgical risk, and we have various risk scoring systems. We have ASA physical status. In addition, specific scores like model for end-stage renal disease, liver disease, child Cook score, and other scores which are available. We should definitely know the contraindications for surgery. So acute hepatitis or acute liver failure, alcoholism-associated hepatitis if it is an acute phase, and severe chronic hepatitis. We should be really careful, and we should optimize if possible before taking up for surgery. However, patients with mild hepatitis, fatty liver, autoimmune hepatitis, Wilson's or hemochromatosis may have a minimal risk because doing the surgery. We know about child Cook score. I will not go into details, but it is a good idea to assess these common endpoints which might be there in these patients and come to a score. Similarly, we know about MELD score, which you need to know about the creatinine, bilirubin. And it is important to know that if it is more than 15, elective surgery should be avoided. And between 10 to 15, we need to be cautious while doing an elective surgery. Similarly, we have vocal pen score. So these are the scores which are available, and there are many which are there online. You have a calculator, you can put in the values to assess the preoperative risk. It is important that these scores are assessed in a multidisciplinary team. Though we don't have absolute cutoff values, but depending on the context, the type of surgery, surgical expertise, anesthetic facilities available, we can take a call. And important thing is that we need to tell the patient regarding the risk involved, so that they are contributing, they agree to whatever is being done based on the risk stratification. Now, patient with the decompensated cirrhosis, we may have a splanchnic hypocontractility, which leads to splanchnic vasodilatation, increased portal blood flow leading to variceal bleeding. There can be activation of the reticular system leading to cardiac index, which is increased. There can be increased catecholamines, which lead to increased sodium water retention. It may lead to ascites. There can be renal vasoconstriction, leading to a hepatorenal syndrome. So these are the important pathophysiology which might be there in a patient with decompensated liver cirrhosis. Now, surgery, the challenge is when to do safely. So that is what we are, as anesthetists, it is our prime responsibility. So two types of surgeries need to be done in a patient with a cirrhosis, which is decompensated. Either it is life-saving, so it may be a cancer surgery, cardiovascular or emergency intervention, where we cannot wait enough to optimize and we need to do, or it is the surgery, whatever we may do, is going to improve the quality of life of patients. Now, coming to patient characteristics, so obstetric jaundice is quite common. It increases the risk of perioperative complications, infections, ulcerations, DIC, wound adhesions, and renal failure. So there are three predictors which have been identified using multivariate analysis. So initial hematocrit less than 30%, bilirubin more than 11, and malignant cause of obstruction, these patients are an increased risk in the perioperative period. So what are the interventions which we can do? So we can do antibiotics to reduce infections. We can do rifaximin to reduce the endotoxemia, which may be due to destruction by the gram-negative organisms. Then we give bile salts or lactulose, which will prevent both endotoxemia and exaggerated renal vasoconstriction. And external hepatic biliary drainage may be done, but there is no specific benefit of one approach over the other. So in asymptomatic patients with significant abnormal LFT, we can actually postpone and get it investigated if it is a purely elective surgery. Now, there are some interventions which we can do to reduce the surgical risk before elective surgery. So the key points to be considered are, what are the treatment of underlying advanced chronic liver disease, nutritional status, treatment of ascites, and reduce the risk of bleeding due to portal hypertension. So these are the specific treatment which we can do. This is pretty standardized, and we should know about the possibilities of the treatment which patient might undergo. And the effect is quite fast. So if you do it in time, so within 3 to 4 days, the patient starts improving. Now coming to the other parts, so we have a coagulation and thrombocytopenia. Coagulation abnormality is there because we know there are a lot of factors, coagulation factors, which are synthesized in the liver. Then portal hypertension may lead to hypersplenism, which leads to thrombocytopenia. Then there is an altered fibrinolytic system, prothrombotic state as well. So overall, there is a system which is not in optimum function, and we need to be careful while selecting the anesthetic technique. The important thing is that usual tests like PT, INR, platelet count, they are not good indicators, and we may need to resort to viscoelastic tests and thromboelastography so that we can actually objectively measure the coagulation derangement that is happening in these patients. So in addition, we need to optimize anemia. We can give iron, folic acid, B6 and B12. We have to treat infections. We have to improve the renal function, and we need to avoid acidosis as far as possible. FFP can be given if required with a documented deranged PT-INR is there. Now, ascites is quite common in these patients, and we need to assess and manage them before surgery. Usually, these patients are on diuretics. Then paracentesis before surgery is a debatable thing. So if it is patient has a very large volume ascites which is causing a respiratory discomfort to the patient, he's having a restrictive lung disease because of ascites. So it is a good idea to drain, but we have to be careful because this may lead to dehydration. So adequate intravolume replacement of fluid without causing a fluid overload maybe should be done. So we may use an albumin to balance for the fluid loss. We should monitor for the kidney function test serially, and also we can check the possibility of infection in the ascitic fluid. So once we do abdominal paracentesis, so we need to see the cell count, protein, and serum albumin gradient. So standard treatment is we have to discontinue alcohol, discontinue the medications that may decrease renal perfusion, need to give a salt-restricted diet, and diuretics like spironolactone are started. The important thing is, so they can be electrolyte derangement because of the diuretic if it is an acute start of diuretic, and so we need to monitor the electrolytes, and we have to be careful while assessing them. Now coming to encephalopathy, this is quite common, and it may lead to a cognitive decline in the patients. It may be precipitated by stress in the perioperative period, which may be due to sepsis, diuretic use, hypokalemia, constipation and GI bleeding, use of depressant drugs like narcotics and benzodiazepines, hypoxia and azotemia. So the symptoms may vary from initially euphoria, slurred speech, ataxia, then can be in altered reflexes, somnolence and confusion to loss of reflexes. So this is a broad variety of symptoms the patient might present with. Another important thing is that it may be mistaken to a delirium, which might be there in these patients, especially elderly, because of other reasons. So we have to be really careful in these patients and need to evaluate properly. So if a patient has an acute hepatic encephalopathy, we have to initiate a supportive care with the help of hydration, nutritional support, try to find the precipitating cause as I discussed and resolve them. It is a good idea to give a non-absorbable disaccharide like lactulose. And then we see the status of the patient within next 48 hours. So if it is improved, we have to continue with this lactulose, and we can see the mental status over a period and then take him for surgery. However, if the patient is not improved, then we need to add rifaximin and then again assess after 48 hours. And if it is still not improving, we can consult a hepatologist if required. Now, drug dosing therapy includes, these are the doses which we need to give, and we have to be really conversant with the precipitating factors, and these are common ones like constipation, GI bleeding, hypoglycemia, hypokalemia, hypovolemia, hypoxia. All of these things can be present in the perioperative period, before surgery, during surgery, and after surgery, and we need to be aware of these possible factors which need to be reversed. And if we take care of hypovolemia, hypokalemia, hypoglycemia, the situations improve drastically. Renal dysfunction is also common, so due to hemodynamic derangements. So it increased by diuretic use of nephrotoxic agents like NSAIDs, large volume paracentesis without proper volume replacement, infections and GI bleeding. In addition, the perioperative period, there are a lot of fluid shifts and there's a fluid loss. So we need to monitor the renal function closely. And we may use vasoconstrictors like norepinephrine or vasopressin if needed. As I discussed, electrolyte abnormalities, specifically hyponatremia and hypokalemia, are quite common because of the changes occurring during the cirrhotic patient. And we need to measure them regularly and need to correct if the symptoms are there along with a deranged electrolyte. So pulmonary disease we can see. Coming to nutrition. So malnutrition and sarcopenia is quite common. So we have to ensure a good amount of calories which are there depending on the resting energy expenditure of the patient. So this should be about 30 to 35 kilocalories per kg, and protein is roughly about 1 gram per kg. So if the patient has a hepatic encephalopathy with raised ammonia, the amount of protein needs to be reduced. Then we have to also give supplementation of fat-soluble vitamins, specifically A, D, E, and K. And if needed, a PEG can be done. It is, however, contraindicated in patients with ascites and in patients with portal hypertension, which may lead to a lacerating abdominal wound, which may be difficult for the patient. Another important problem in these patients is pain. So abdominal pain is quite common, which is due to hepatic capsular distension and splenomegaly. So opioids should be used cautiously, and if required, we need to use fentanyl. Multimodal opioid sparing techniques are best suited for these patients. So we can use paracetamol up to 2 grams per day, and avoid using NSAIDs because this may lead to a variceal bleeding as well as renal dysfunction. Now coming to prehabilitation. So prehabilitation is an important concept nowadays, and specifically in these patients, we can do a psychological, physical, and mental prehabilitation. So exercise has been advised to these patients up to 3 times per week. The important thing is it has to be supervised by a physiotherapist. It should be high intensity interval training, and the focus is on endurance and strength. And so what is suggested is 2 to 3 times they can come to the hospital under the physiotherapist observation, and 3 to 4 times they can do at home, and it can be a low intensity training so that overall they build up their strength and endurance. Nutritional support is important, and I have discussed already regarding that. Now, mental support is very, very important, and patients, in addition to cognitive derangement which might be there because of liver disease. These patients are also prone to a lot of anxiety and depression, and this needs proper patient information. We need to discuss about the relaxation techniques, and a decision making should be shared with the patient. And smoking cessation is important, and we need to counsel the patients for cessation of smoking if this patient is smoking. Now coming to cognitive rehabilitation. So the important concept of cognitive rehabilitation is that we need to prevent post-operative cognitive dysfunction and delirium, and yet overall improve the post-operative functional status. So we need to assess the patient clinically for neuropsychological assessment. We need to educate the patients. Then we have to assess for brain regions in the patient and see the strategies which might help him. This may be home-based activities and with telephone support if needed. Also, we need to focus on the memory function and attention of the patient, and all these activities are usually home-based because that will improve the compliance, and we can give a telephonic support if needed. And we need to assess them again and again and see whether the cognitive education is working or not, what is the feedback the patient is giving, and overall how is the improvement in the perioperative period. Now, these are the risk factors for cognitive dysfunction. So, in addition to elderly, a baseline cognitive impairment which might be there in patients of liver dysfunction, dementia, sleep disturbance, alcohol. So you can see a lot of them are quite common in patients with liver disease, and so they have become a higher risk category for a post-operative cognitive decline. For intraoperative factors, we can see the duration of surgery. Usually these surgeries are prolonged. Then we have associated intraoperative hypertension, which is quite likely considering these might have ascites. So they have a lot of hemodynamic fluctuations. Then anesthetic techniques which may use. So we try to avoid using benzodiazepines and opioids as far as possible in these patients. Then postoperative factors like prolonged ICU stay, sepsis, uncontrolled pain, deep sedation, so fluid overload, sensory deprivation, anemia, all these things might be additional risk factors and quite possible in these patients and need to be controlled for preventing cognitive decline in this patient. And another important concept is cognitive exercise or preconditioning. So this exercise is, as I discussed in the flowchart earlier, so it will target the memory, speed, attention, flexibility, and problem-solving functions. So these are various cognitive domains which need to be tested. Then they try to find out the problem areas and then advise exercises accordingly. So conditioning will include acupuncture at specified locations on the scalp combined with transcranial electrical stimulation. What they do is if they find specific cognitive domain dysfunction, so those areas are stimulated in the brain depending on the deficit they find, which tend to improve the cognitive function over a period. Now, another important thing is post-operative management. Considering these patients can be tricky to handle, so we should be aware about problem areas. So we need to be careful about nutrition. Specifically, dextrose has to be given in this patient, considering liver function can be a borderline. Then acute kidney injury is common, so we need to discontinue diuretics and lactulose. If there is a dehydration, we have to be careful with fluid management and may require to give albumin if needed in select patients. Then postoperative analgesia is also important. So mostly it is opioid-free, or if at all needed, weak opioids preferred. No NSAIDs, and paracetamol and regional analgesia-based analgesia need to be given. And for ascites, we need to limit perioperative fluids, avoid volume overload. Spontaneous bacterial peritonitis may be there, so prophylaxis need to be given. And try to give low sodium diet and diuretic with careful fluid monitoring and electrolyte monitoring in these patients. So this was my last slide, and we can take questions if there.
Yeah, so thank you to Dr. Nishkarsh. It was a very detailed and comprehensive talk. So we will take the questions in the end, well, after all three lectures. So for the next lecture, I invite Dr. Jyoti Sharma, Dr. Jyoti Sharma is Associate Professor from AIMS Bathinda, and she will be speaking on the topic of this perioperative management of patients with liver disease for hepatic or GI non-transplant surgeries. Dr. Jyoti, please.
Good evening, everyone. Am I audible?
Yes, you're audible. Please carry on.
Good evening, sir. Actually, I had an issue with my laptop. I am joining from my phone, so I request the organizers not to mute my phone. So, first of all, I would like to thank the ICA platform for giving me this opportunity, and a special thanks to Dr. Sohan, sir, for inviting me here on a very short notice. So I would speak on the topic perioperative management of patients with liver disease for hepatic or GI non-transplant surgery. Basically, I would focus on hepatectomy now most of the time, and the pathophysiology and the prehabilitation part has been covered very well by the previous speakers, Dr. Lalita and Dr. Nishkarsh, sir. So I would rush through the initial slides. So as we all know, liver is a large complex organ with a multitude of different functions. The liver disease can be acute or chronic. The common causes of chronic liver disease include viral hepatitis, autoimmune hepatitis, non-alcoholic steatohepatitis, Lennox cirrhosis, cryptogenic cirrhosis, or it could be metabolic diseases such as hemochromatosis and Wilson's disease. So the different types of hepatopancreaticobiliary and GI surgeries can include pancreatic small bowel surgery, retroperitoneal sarcoma surgery, GB, colorectal surgery, stomach surgeries, or cytoreductive surgeries, which is very common these days, and liver resection. So the liver-specific surgical procedures can include transjugular intrahepatic photosystemic shunt procedure, the radiofrequency ablation of hepatic tumors, the transarterial chemoembolization, hepatic resections, and donor liver hepatectomies for liver transplants. Coming on to the clinical presentation of the patients posted for hepatic resections, there could be a history of previous blood transfusions, drug abuse, excessive alcohol intake. We need to know the family history of jaundice, anemia, hereditary liver disease, adverse reactions to anesthesia, the use of analgesics and alternative medications, and prior chemotherapy if it is being given. And the symptoms of underlying liver disease should be looked for, that is jaundice, Palmer erythema, spider nevi, ascites, or hepatosplenomegaly. Now, coming on to the preoperative evaluation and optimization, it is important to diagnose the underlying liver disease, correction of the underlying conditions. We have to estimate the functional hepatic reserve and assess and stratify surgical risk. If liver dysfunction is suspected, then elective surgery should be deferred until extensive evaluation is made. The markers of severe disease include jaundice, coagulopathy, ascites, and encephalopathy. Dr. Nishkarsh has already talked in detail about all these factors. Now, the investigations have also been covered in detail. I would touch upon in short. We need to do the lab test to determine the presence and cause of liver injury, whether it is due to cell necrosis or cholestasis, and to determine its severity. So various liver function tests have to be performed. Markers of viral hepatitis A, B, and C, and indocyanine green clearance is important, and ultrasound and Doppler sonography. So in preoperative optimization, nutritional assessment has to be done. the disease-related malnutrition has a high prevalence in cancer patients, 40 to 80%. Subacute and chronic deficit in energy, protein, and micronutrient intake, resulting in changes in body composition and reduced body function, which in turn can negatively impact clinical outcome. And approximately 20% of patients die from consequences of disease-related malnutrition rather than from the primary disease itself. So there are various nutritional assessment tools, which include Nutritional Risk Screening 2002, which was given in 2002, Malnutrition Universal Screening Tool, Mini Nutrition Assessment, Malnutrition Screening Tool, and Subjective Global Assessment. We can follow any of these assessment tools, and we need to assess the nutritional deficit of the patient. Then the various risk scores, the Child-Pugh classification, model for end-stage liver disease. These are the most commonly used. Others these days have used our Mayo risk score and the vocal pen risk score. And many other risk scores have been defined in literature. So the Child-Pugh classification score, it includes the factors encephalopathy, ascites, bilirubin, albumin, and prothrombin time. And depending upon these factors, the liver disease can be classified into class A, B, and C, and is given 5 to 6 points, 7 to 9, and 10 to 15 points in class A, B, C respectively. The MELD score is nowadays being used for, that is the model for end-stage liver disease, and is calculated by using serum bilirubin, INR, and serum creatinine levels. The MELD score is important where there is an existing cirrhosis and hepatocellular carcinoma, but it should not be used in the context of elective hepatic resection with normal liver functions. Now, coming on to the rules for hepatic resection in cirrhotics. It is indicated in Child-Pugh Turcot class 1, and if there is a platelet count of more than 1 lakh, there is no clinically significant portal hypertension is present. Anticipated remnant is more than 40 to 50%, and indocyanine dye retention is less than 15%. Now, what is remnant liver volume? It is the amount of future liver remnant volume that is fundamental for hepatobiliary surgery, representing an important potential risk factor for the development of post-hepatectomy liver failure. So if the functional liver remnant volume for a safe resection, it should be at least 20 to 30% in normal liver. However, if the liver is cirrhosed or there is cholestasis or steatosis, it should be at least 40 to 50%. It is done by using CT, MRI, using mathematical models. Now, there are various measures to increase the FLR if it is low initially. One is portal vein embolization. Then there is transarterial chemoembolization TACE. It causes hypertrophy of the rest of the liver. And another is transarterial radioembolization using yttrium microspheres. Now, a little bit about transarterial chemoembolization. It is the most commonly used methods from the above three. It is a neoadjuvant treatment before liver resection. It improves preoperative diagnosis, reduces tumor size, both primary nodule and associated with microscopic lesions, and it increases the resectability. It prevents cancer cell dissemination during surgery and sterilizes undetected lesions. So, by increasing the functional liver volume, it improves the survival rate. Now, coming on to the prehabilitation, which has already been covered in detail by the previous speakers. The patients, the physical prehabilitation, the respiratory prehabilitation is very important to prevent the post-operative pulmonary complications. We can advise preoperative intensive spirometry and respiratory muscle training, which should be continued in the post-operative period. Now, one important factor is the enhanced recovery pathway, which includes the optimization of the patient starting from the preoperative, continuing through the intraoperative and the post-operative period. And this is recommended to reduce the post-operative complications. In the preoperative period, we have to start from the pre-admission counseling, fluid and carbohydrate loading, The fasting should not be prolonged. Bowel, there should be no or selective bowel preparation, antibiotic prophylaxis, thromboprophylaxis, and no pre-medication is advised these days. In the intraoperative period, short-acting anesthetic agents should be used, mid-thoracic epidural anesthesia or analgesia. And avoidance of salt and water overload, and minimal or no drains should be put to the patient, and maintenance of normothermia is advised. In the post-operative period, the mid-thoracic epidural anesthesia or analgesia, and avoidance of salt and water overload, early removal of catheters, early oral nutrition, early mobilization, and stimulation of gut mobility is should be done as soon as possible. Now, coming on to the intraoperative concerns, blood loss, fluid management, ischemia time, and the anesthetic technique. We need to focus on all this. Now, coming to the blood loss, it is anticipated that there can be a 700 ml to 1.2 liter blood loss in liver dissections. Implications of intraoperative blood loss include increased perioperative morbidity and mortality. Excessive use of vessel occlusion technique in the postoperative can cause postoperative liver failure, and blood transfusion itself can result in immunosuppression, infection, and recurrence of malignancy. So there can be a few measures for reduction of blood loss, which can be non-surgical techniques or surgical techniques. The surgical techniques include inflow vascular occlusion by hepatic pedicle occlusion, continuous Pringle maneuver or intermittent Pringle maneuver, and the total hepatic vascular exclusion and selective hepatic vascular exclusion. So the non-surgical techniques include preoperative autologous blood donation. A low CVP is demanded these days by many surgeons from 0 to 5 centimeter of water. Then aprotenin tranexamic acid can be used, and coagulopathy should be corrected and maintain calcium during blood transfusion. Normothermia should be maintained, and cell saver technique can be used. So coming on to the fluid therapy, the fluid should not be too much, too little, or it should be normovolemia should be maintained, and goal-directed fluid therapy is advised these days. So the goals which are used, are stroke volume variation, pulse pressure variation, cardiac index, mixed venous oxygen saturation, stroke distance, and lactate. These can be monitored by the cardiac output monitoring using the lithium or the flow track vigilio or the trans-esophageal echocardiography. So coming on to the intraoperative monitoring, which is needed for these patients, the standard ASA monitoring, then invasive monitoring, arterial blood pressure, CVP with or without SCVO2, cardiac output monitoring, then ABG with arterial lactates, core body temperature, in case of CRS HIPEC if it is being performed, then ETO2, intraoperative blood lab investigations, and urine output. Now the anesthesia technique for induction and analgesia, standard general anesthesia with epidural analgesia is advised, and in liver dissection, however, epidural is debatable, and opioid sparing anesthesia is preferred. Now, post-operative pain management is a very important component for in these patients. The multimodal analgesia is advised starting from the preoperative period, and apart from the pharmacological agents, the regional blocks are used these days. So different pain management modalities include epidural analgesia, preperitoneal catheters, continuous wound infiltration of local anesthesia, erector spiny block, quadratus lumborum block, tab block can be used, and intrathecal opioids are also used by some. Now, central neuraxial block, it is controversial. It is found to be safe in many studies. However, derangement in coagulation peaks at 2 to 3 days post-operatively, and it returns to normal thereafter. So if epidural catheter is placed, it should be removed only after 3 to 5 days after ensuring adequacy of coagulation parameters. The epidural and block has a few advantages and also a few disadvantages. It used to be the gold standard for pain relief till many years. However, these days it helps to reduce CVP during the transaction phase, and it also helps in early mobilization and immunoprotection and reduces the hospital stay. There is a failure rate of approximately 19 to 20%. It requires urinary catheter for a longer duration. A post-operative coagulopathy may delay the removal of the epidural catheter, and hypotension may lead to increased use of vasopressors. So interfacial plain blocks can be used, which include quadratus lumborum block can be done, erector spinae block can be done, or bilateral oblique subcostal tap block can also be performed. Now coming to the thromboprophylaxis, in a patient with normal liver parenchyma, major hepatectomy is a risk factor for pulmonary embolism. So thromboprophylaxis with low molecular weight heparin or heparin should be started 12 hours before surgery, and it should be continued till 4 weeks after surgery. And so the timings of epidural insertion and removal should also be taken care of. Compression stocking should be used intraoperatively as mechanical thromboprophylaxis. Now, post-operative complications, it can be acute renal failure, bile leakage can occur, post-operative infection, coagulopathy, glycemic control, nutrition and hypophosphatemia, and fluid and electrolyte imbalance can occur. Post-operative liver failure, it is the impairment of liver's ability to maintain its synthetic excretory and detoxifying functions, as characterized by an increased INR and hyperbilirubinemia, and it occurs on or after post-operative day 5. So the incidence is 0 to 30%, and clinical features include worsening coagulopathy, hyperbilirubinemia and cephalopathy, and associated with renal failure, respiratory compromise, and features of sepsis. It should be anticipated and should be taken care of. So the take-home message, patients with liver disease for surgery carry huge morbidity burden. A multidisciplinary team approach with appropriate pre-operative planning, communication, and prehabilitation is of paramount importance. Adequate analgesia and fluid management with avoidance of major intraoperative blood loss and transfusion will reduce the physiological stress and lead to fewer post-operative complications, and early mobilization and nutrition will reduce complications in most of the patients. Thank you all for your patient hearing.
Thank you very much, Dr. Jyoti.
Thank you, sir. Apologies for the delay in the internet connection. Few times it was disrupted in between.
This is all not in our hand sometimes, so it's okay. So now we had all 3 lectures by Dr. Gauri, Dr. Nishkarsh, and Dr. Jyoti. So we can take questions for all these 3 lectures.
Dr. Sohan.
Yes, sir.
I have a question. It's not in the chat box.
Okay.
Regarding the cognitive exercise, Nishkarsh was telling, who decides about the cognitive exercise and who controls the exercise? And when you think you got the adequate response from the patient regarding the cognitive exercise?
Yeah, Dr. Nishkarsh, please.
Sir, good evening. So there are specific psychoanalysts which are there. So psychologists will be assessing the cognitive domain of the patient, and there are such scores which they use. And depending on assessment, they will advise, and it is pretty much under their care. So they will decide what is needed and how frequently and how much, and they are reassessed after starting the cognitive exercises, and 7 to 10 days, 15 days, they again reassess, and they keep on doing it till the particular level is reached.
The psychotherapists do it or physiotherapists do it?
That's basically a psychologist, sir. Psychotherapist, psychologist, they will do it, sir.
Is it being done anywhere in India?
Sir, it is probably done as a project mode, not a routine method used for care in patients.
Yeah. Okay, thank you.
Sir, I know I'm a speaker, but there's something that I would like to discuss with Dr. Nishkarsh, because he works in Onco Center with Dr. Sohan, Dr. Reshma, Dr. Vandana. I can see she's there. She's just, I think, recovering from COVID. And I thank Dr. Jyoti for taking up her talk. I was asked this question today by the surgeon, that how do you put all the three together in a center where you have a very high volume? How do you follow up the patient to ensure that they're actually complying with whatever you're telling them to do, whether it's complying with their de-addiction, complying with their nutrition, complying with their exercise? Do you have a format, a formula, a performer that is filled, and then you look at it serially every time they come back to the OPD till they actually come back, they get onto your table for anesthesia? So anyone who can take this.
I think Dr. Vandana can take this question. So it says, because Dr. Vandana is there?
Yes, my voice is a bit off. So I don't think you can be 100% compliant with everything. It's in a real life situation. But in Tata, compliance with de-addiction, at least what we see, is very, very good. There would be an occasional odd smoker who would, still continue to smoke. But by and large, patients, when they come or when they become aware that they've got malignancy, they actually, quit their habits. So compliance with habit, at least practically, we haven't seen any issue with. Compliance with physiotherapy and nutritional or a multimodal prehab is easily doable. But I again here would say that it cannot be 100%. We have to live in a utopian world to be 100%, especially facing the volumes that we receive in data. But I always tell my surgeons that from the time they decide upon surgery, they should send the patients for nutritional screening and assessment. And also the same thing for physical rehabilitation, not only in terms of just physiotherapy, but also making them exercise. And by exercise, what we do here is we do not, resort to any heavy machinery. We just tell them to walk as briskly as they can for at least 30 to 45 minutes a day till they come up for surgery. And this must be done at least 5 days a week. So, it's very doable, provided the surgeons are, in sync with you and they agree with prehab and they believe that prehab actually makes the patient recover faster. I hope that answers your question.
Dr. Nishkarsh, do you do anything different?
No. Okay. So, whether Dr. Vanna has answered it very well. So, in our setup, so considering it is a high volume center, only government setup providing complete oncology care. So, the volumes is a big deterrent. So, what we do is, we have a lot of protocols being tested in a project mode. So, because a lot of thesis work going on, other projects going on. So, for those purposes, so those patients who are in that, enrolled in that, so they are being followed to the course. So they be ensured that everything is being done, protocol is being followed, and we do see outcomes, because whatever we may say, this rehabilitation eras is a paradigm shift from the traditional method we have been doing, whether it is anesthesia or surgery. So it is an outlook change, and it needs time, and we need to have our own evidence before we are able to do on a larger scale. Another important thing which Dr. Vanna highlighted, and I will reiterate, is that it is not that we don't have time. So cancer surgery doesn't mean we have to operate the next day. And mostly we have roughly about 2 to 4 weeks before the patient comes to the hospital and he actually is being scheduled for surgery. So that 2 to 4 weeks is a good enough time for rehabilitation for these patients. Whether we have anemia correction, we give iron total IV, or we do a physiological exercise training of these patients. We do other comorbid condition optimization. So that is a good time which need to be utilized appropriately. Only thing we need to do is the patient should come to us the day he visits surgeon for a possible surgery. So then you get enough time for optimization.
Radhakrishnan, once again, I humbly disagree with certain things which Nishkarsh was telling. I doubt whether all possible in a high volume center in the government. A high volume center in a semi-private or private institution, well, things are possible. But what I was trying to refer, well, it's all patient management by the treating physician and how far we can get involved in all these things. We may be seeing the patient prior to the surgery, as well as immediately after the surgery. If the patient is coming into our care, we may be able to see it. At that time, we may be able to give correction or say quick relief remedies for getting the patient upright. But again, all those things possible, rather than telling that patient is not fit enough now to undergo surgery, I really doubt whether anything is possible in our hand, because we are in receivers. And well, I believe you will all agree to me on this particular matter. Well, it's good that we know about all those particular things, whereas our surgeons, do they agree to all these things, and how we may be able to interfere in the patient's management, except for the period of time when the patient is with us. Well, one can definitely say this patient is not optimally worked out, or say patient cannot be taken up now for a good result or a satisfactory result. But how the surgeon going to believe it, and how he going to understand, or how he going to accept our recommendation. And again, all patients cannot wait for that long. Certain cancer surgery, well, they like to do it fast. They don't want to wait for 3 or 4 weeks time. They may say so many reasons that, well, patient may deteriorate further and we will be responsible to all these things. But certain patients in the early stage of cancer, probably we may be able to do well with the textbook understanding of matters. They should be prepared well, optimized for that particular work, and prehabilitate. This is my feeling. I rather put it across to you all, whether we should go in which direction in this particular matter concerned.
Sir, you are right in your sense. So, but that's why I said we are doing it in a project mode. So we have a lot of postgraduate thesis going on. So
Yeah.
because we have to show that the surgeon that the things are working, and eventually they will also adapt. Believe me, if we correct anemia in time, we have basic simple exercises told to the patient. We do nutritional correction. These things have a good effect on the post-operative outcomes, which surgeon is also worried. So if there is a post-operative biliary leak post-surgery, so surgeon is also worried. No, he doesn't want patients to have a complication in the immediate post-op. So we are definitely in high volume center, you cannot do it for all patients, but select patients, you can definitely show a change and then make a protocol so that everybody follows when they come to us. Another important thing you said is, so mostly we have at least 2 weeks. So suppose a patient walks into the hospital. So clinically malignancy is possible. So they will do a CT scan, they will do a biopsy or an FN to prove it is a malignancy. Only then they post for a surgery. So minimum 2 to 3 weeks is minimum, even if known of faculty or somebody who is a so-called VIP will go, because that is a minimum time required for the system. You cannot get a biopsy done the same day and reported the next day. That will be difficult. So that 2 weeks is a golden period for us to do best possible optimization. It cannot be 100% ASA 1 patients mostly. So it may be still ASA 3, but best optimized in those 2 weeks for the surgery. So that is what we do. We usually do not cancel the patient because a lot of factors are there in malignancy which will ensure that it needs to be done in a specified time. But optimization to the best possible thing should be tried, at least for these patients.
We try.
Yeah, I think I agree with what Dr. Nishkarsh is saying. And I think, as Vandana said, the surgeons need to believe. And in TMH, at least I think we are lucky that our units do believe that all these things help. And when they decide the patient is for surgery, they do refer from their side only to our nutritionist experts and to physiotherapy. IV iron is decided in pre-anesthetic checkups, and we also run a high-risk JC for all high-risk patients. The indications might be from the anesthesia point of view or from the surgical challenge. So we also end up seeing the patients. And at TMH, because of the workloads, they don't come up for surgery. Majority of the cases, we do have a wait time of 2 to 3 weeks minimum, if at all. For pancreas, currently it's over a month. So we do have this time, which is shown in most studies to be adequate. 3 to 4 weeks of prehab. So at least in TMH, the surgeons are quite tuned to the prehabs, and we are getting all these things done in majority of the patients. So I guess that's how it works at TMH.
Yeah. So, Dr. Kumar Balani from USA, he wants to say something. Sir, please.
Yeah, thank you. Thank you for giving me the chance. I think you all have brought up very good points. In America now we have what's called the surgical home, which means, especially in high volume centers, you can have a team where these patients are evaluated and they go through the process of pre-procedure rehabilitation, all that, and it goes, without any difficulty. And the anesthesia departments here have taken charge of that. And this is an opportunity for anesthesiologists in India to take over this role, because that can be part of the perioperative medicine role that we play in the care of patients that are undergoing surgery. And they've demonstrated value in having the surgical home concept, where you have a team. The patient goes in to the surgeon's office. They decide surgery is needed, goes to anesthesia. Anesthesia decides on what protocol is needed for the rehab, how much rehab is needed, and then they schedule the procedures accordingly. And that has worked well in the United States, both from improving patient outcomes as well as efficiency during the surgical care of these patients. So that thing can be instituted in India very easily now, I think, and it would be a good role for the anesthesia community to come in and take charge. Just my few cents.
Dr. Belani, my question is that in the United States of America, everything is run by insurance, and you have to show benefits and outcome by showing that this all decreases the length of stay in ICU and hospital stay. So how are you all kind of getting it in the system, and how have you all made it as a point where you can show that it has made a difference, so that when the surgeon decides that the patient needs surgery, he refers very early to the anesthesiologist?
There are many papers out on this topic, and most of them have demonstrated benefit, and the insurance companies have understood the benefit of this. They actually save money by doing this, and you can look up the literature. There'll be lots of papers on every aspect of surgical procedures. Orthopedics was the number one that they started. It spread to colorectal cancer and other cancers and malignancies. It's gone on to almost everything you can think of. So there are teams that work on cardiac surgery is another one, and there's plenty of literature to support this. You can go to the American Society of Anesthesiologists website, and there's information there on the surgical home. Many papers listed over there.
All right. Thank you, Dr. Belani.
Thank you. And another thing, today, colorectal oncosurgical work carries maximum care. and people who are dealing with rather take an elaborate steps. But is it applicable all the time? When you take ethical consideration in these matters, especially in terminal cancer or say stage 3 cancer, whether anything of these things is possible, or do away with some sort of palliative work and give terminal care. Is standard care possible when we are analyzing ethically? Even in America or in the UK or Western Europe, whether that is possible these days. Because treatment is a costly affair. Everywhere, even though it is the insurance at most of the places controlling the surgical worker, people believe in rationing out services to all. So to who it suits well and who is the most needy is given the treatment free of cost. Whereas in the corporate sector, a different ballgame is played. Do anybody has objection to this matter? Which I am putting it straightforward.
So,
Anybody can come with an answer. Because most of the times you are forced to accept a case.
so Dr. Nishkarsh, Dr. Gauri, and Dr. Jyoti, anybody wants to answer something? Do you want to answer?
Nowadays,
I think more than us, probably the surgeon is equally worried about his own mortality, morbidity. So
Yeah.
I think everybody walks on eggshells when they come to sick patients, and everybody will give a sick patient an opportunity to get better before they put them under the knife. So if literature definitely tells us that sicker patients do better with prehabilitation, and they do comply once they know that they have some kind of a disease that's likely to be terminal. So if it benefits somebody, it should be offered to them. Taking up from where I started off this conversation, what we have done a very simple thing, that one of the good things we have at TMH, even at our institute, we are part of TMH, is that we have an electronic system where whatever the surgeons write or whatever the anesthetists write, they immediately come to know. So just like you have a daily chart where you write, the pulse, blood pressure and everything, we have formed a chart where you write the height, weight and everything of the patient, along with obviously the investigation. So each time the patient comes back to you, you kind of keep a track of, you just simply look at it. So and we've seen with prehabilitation, what is just happening, that someone who's likely to have lost maybe 10 kgs has just lost about 4 kgs. So we may not have dramatically improved them, but we have not let them deteriorate. So that's, I think, one good thing that's happened from trying to implement prehabilitation in our setup. So that's something where we wanted to share.
Okay, sir.
I think start with Dr. Sohan. So I would like to now Dr. Sohan.
Yeah, so it is 8:30, so I think we should go for the panel discussion.
Yes. So Dr. Sohan, Dr. Reshma, and
Balakrishnan, sir, okay, sir?
Okay, go ahead.
Okay, thank you, sir.
So let's side interaction.
A small team from the DMG called GI unit. We have Dr. Sohan, we have Dr. Reshma and Dr. Vandana. They're all professors in anesthesia with lots of publications, lots of book chapters, lots of awards. They worked closely with together. They work in a very protocolized way. They do evidence-based work. So, and they have Dr. Indira Gurajala from Hyderabad. So I now ask Dr. Solanki to go ahead with the panel discussion.
Okay, so we are at the this last panel, last thing of the webinar is the interesting case panel discussion. So I invite Dr. Reshma Ambulkar. She is a professor in my department of anesthesia, critical and pain at Tata Hospital. I invite Dr. Nishkarsh from Delhi. I invite Dr. Indira Gurajala. She is additional professor from Nizam's Hyderabad. and Dr. Jyoti Sharma, she is Associate Professor in AIIMS Bathinda. So welcome all. I invite you to for this case. So I will just discuss one case. So I will go ahead in this case. So this case is a 68-year male, retired government servant. He's 49 kg, BMI 21. He's hypertensive since last 15 years on metoprolol 25 mg BD plus Talma Cytron 40 OD. He's also diabetic since 50 years on OHA. He's asthmatic. And he's having a history of chest pain, 5 years back, but there are no details available on that. But he's on atorvastatin 20 mg and aspirin 75 mg since last 5 years. And he's an ex-smoker. He left smoking somewhere 2 years back, and he smoked for almost 10 years. So he's diagnosed with a CA head of pancreas, and he's posted for the Whipple's procedure with portal vein resection, and is tentatively planned for surgery 2 to 3 weeks after this. So when we checked with the PSC, the effort tolerance was hardly 1 floor, and on lab the HB was 8.7 gram percentage, platelet around 120. TLC 7,000, albumin was low 2.6, globulin was 4.2, creatinine was 1.3, PSC BP was 168 by 92, heart rate of 84. His ECG showed LVH and 2D echo shows LVF of 55% with the PASP of 45. So, and I already told you this PSC BP and all this. This patient is referred to you by HPB surgeon. He wants you to see this patient. So what next? So I'll ask Dr. Reshma what next. What will you what additional test or what additional referrals or additional investigations you want to do with this case?
So this patient definitely has multiple comorbidities, is posted for a major surgery, and also the labs which currently we have the patient has a hemoglobin of 8.7 with a low albumin with a reverse AG ratio. So he will definitely benefit by prehabilitation, what we're talking about. But additionally, I would also looking at all the comorbidities. First of all, will need optimization of all his comorbidities. Hemoglobin 8.7, we could do iron studies further and treating his anemia. And Sohan, when is he posted for surgery? I mean, how many weeks do we have?
Posted for around 2 to 3 weeks. They are saying that 2 to 3 weeks they can postpone. So approximately 3 weeks we can say.
Okay. So if we have 2 to 3 weeks, we can first of all refer to a physician for all the comorbidities optimization. Also to the nutritionist, because his albumin is low and there's a reversal of ratio, and also to the physiotherapist for exercises, and further, because of his comorbidities and with the major surgery coming up, I would like a stress test, a Dubut stress test on him. But first we could refer it to anemia clinic as well, whether for after the iron studies are done. So we can start from there. I mean, everything can go together. We don't need to wait one by one, but we can do multiple referrals at the time, so that all the different specialties can start working on the patient to get him fitter.
Okay. So Dr. Indira, are you agree with Dr. Reshma that this patient cannot go for surgery upfront? We need to have more tests or more referrals or more investigation, something like that?
Yes, sir. If there is adequate time between first visit and to the time the patient is posted for surgery. I think all measures should be taken to optimize the patient, whether it is the prehabilitation, the exercise part, the nutrition part, and the pre-op anemia correction. And because even 2 weeks is better than, not having any kind of prehabilitation. So every measure should be taken for in implementation of the prehabilitation.
So one more thing I forgot, the patient is a ex-smoker, also asthmatic. So I would also refer him to our respiratory physician and get a PFTs done on him.
Okay, so that PFT is required, and Dr. Nishkarsh, PFT is required according to you also?
Dr. Sohan, can I go to the next slide, please? Next. So it depends actually. So what we do at our setup is, so if the patient is able to do a CPET, so then we can get all objective parameters. We can see the cardiopulmonary interaction, and then the decision becomes more objective. To this patient, however, in this patient, it may be difficult for this patient to do CPET also, because considering the effort tolerance is little poor.
Yeah.
Only one floor he can.
So the main thing, because that only he can hardly walk, he can hardly climb one floor, and doing a CPET for this patient is, I think, is not possible, or maybe not really good. But as Dr. Reshma mentioned, that we can do a dopamine stress test, like that. In that way, we can see the heart, and if we can do a PFT, we can see the lungs. So, do you think that PFT is necessary in this case?
PFT probably yes. Dopamine stress echo, we probably usually do not get it done at our setup. We take a risk depending on the situation, and if CPET is not feasible, as in this patient, we sometimes do 6-minute walk test, which is relatively easy for such patients, because we
So like, if you want to assess suppose this patient is having is on a wheelchair, or is having some knee issues, he cannot walk, then still you don't do the dopamine stress test, something?
The routine we do not do. If we have a baseline echo, there is no chemotherapy which might have affected the cardiac function. Then we hardly get a dopamine stress done for the patient's post-treatment oncology surgery.
Okay. So that PFT is required, but according to you, right?
Yeah. And this is more for logistic reasons, because it becomes really challenging to get a DSA done. But yes, if possible, it will be a good idea to get this done for the patient, because then you know what levels of heart rate and the blood pressure patient is broadly tolerating, and you can actually customize your anesthetic technique accordingly.
Nishkarsh, you all must be getting a DSC done at AIMS itself, isn't it?
We do not get it done because of logistic reasons. So if
it is done in AIMS, but
the facility is there.
Okay.
We do not do
in PMH we don't have. So in fact, we have to send the patient out to get a DSC.
No, but we have at our setup, but logistic issues are there. So we hardly get it done. We try to do without a DSC. We have the method.
I'd like to add something.
Yes, please.
Yeah, sir, it's a good idea to get a PFT done, but I think more than that, it is better that we already have 2 to 3 weeks, so we start the patient on incentive spirometry, and we counsel the patient to do high intensity exercises so that the lung function and the cardiac function improve. So PFT would be an investigation, so it's yeah, it is required in this case, I think. But starting on regular incentive spirometry is important.
Okay. Thank you. So we'll go ahead. So we will like Dr. Reshma advised that we should go for the DSC, and we will probably go for the PFT also, because he's ex-smoker also and is asthmatic. So it's better to do a PFT also in this patient, right? So so that doesn't refer to you, and we are not sure we see this. So now we want to optimize this patient in this 4 manner, right? We want to do, because the patient is anemic, is 8.7 hemoglobin, we can do anemia management. The patient is having a low albumin with a AG reversal, so that nutritional optimization is also needed. Is this patient is having only one flow upper tolerance, so physical prehabilitation and pulmonary prehabilitation also required. And we also need to do the comorbidity management, because the patient is having a multiple comorbidities, history of CAD, history of hypertension, diabetic, asthmatic, smoking, everything. So many comorbidities is also had. So in anemia management, so I asked Dr. Indira, is anemia management really needed, or we can go ahead directly and we can say, okay, well, no need to manage anemia, and we can give the blood intraoperatively if needed. So what do you think?
So there are multiple reasons, especially in cancer patients, you need to correct the anemia, because the incidence of anemia in these patients is very high. And this particular patient is going to have a portal vein resection. So the risk of bleeding is high. So it is recommended by all the guidelines that when the risk of bleeding is high, or the blood volume is going to be more than, blood loss is going to be more than 500 ml, you must correct the anemia, which is already pre-existing. And the other important consideration in cancer is, first of all, this patient is also symptomatic. We do not know whether the symptoms are because of the cardiac or the pulmonary cause. So we will know about it only with further testing. But even anemia is contributory to the symptoms. So correction of the anemia will actually optimize the symptoms also, apart from the pulmonary rehabilitation and cardiac investigations. Then again, because of the morbidities associated with this particular case, we would like to aim at a higher HP. And finally, in cancer patients, not only symptoms amelioration is important, but it is also important to prevent further blood transfusions. So imagine if you have a hemoglobin of 10, 11, you would probably not transfuse these patients. And we all know with transfusion, the risk of malignancy recurrence is more. Even a single transfusion is known to cause cancer recurrence. So because of these multiple issues in cancer patient having multiple comorbidities, anemia itself might be causing the symptoms in this patient. The risk of bleeding is very high in this particular patient. And also because you want to prevent blood transfusion because of the risk of cancer recurrence, I would advise that you should correct the anemia, and whatever the time gap between. Usually you require 4 weeks, but even 2 weeks is acceptable, because when the patient actually bleeds, you have actually provided the substrate for the marrow to put up a response. Imagine if the patient is iron depleted and there is bleeding, the retic count and the hemoglobin improvement will not be as much if there is no reserve as if there is reserve. So even a single dose, 2 weeks, some studies have suggested even just before the surgery also, iron supplementation is useful to increase the reserves of the patient in the patient's body.
Okay. So you think that we must correct anemia before we are going for the surgery, right?
Yes.
Okay. So what are the, so you also mentioned what are the risk of not treating the anemia. So that's okay. So how will you increase the hemoglobin without blood transfusion in the pre-op period?
See, if there is adequate time, usually people recommend oral hemoglobin. But then in cancer surgery, oral iron. The first thing before we go to the treatment, we have to actually diagnose what kind of anemia it is. So documentation of iron deficiency and documentation of any other deficiencies such as folate and vitamin B12 is important. And you must also take a detailed history as to what is the cause of anemia, apart from these nutritional deficiencies, whether the patient is received chemotherapy or the patient is having an ongoing blood loss. So all these factors actually decide, and also the extent of anemia and the time which we have. So if the patient is severely anemic in cancer, any hemoglobin less than 6.5 is considered severe, life-threatening. So you obviously might and if the patient is associated with symptoms, you might actually take the risk of blood transfusion. The other important consideration is whether the patient is having adequate time from the diagnosis to the surgery. If there is no adequate time, or if the patient is not going to be compliant to oral iron, or if the patient is not going to, respond in certain situations, there is GI bleed, that the patient will not improve with oral hemoglobin, oral iron, then you must go for IV hemoglobin. And where there is adequate time and this anemia is not very severe, then probably oral hemoglobin can be, oral iron can be used. So it depends upon the degree of anemia, depends upon the time we have and the cause of anemia, which method we choose. But by and large, if you have a gap of 2 to 3 weeks, then the choice will be IV iron. And there are other modalities in general surgery which are being looked at, such as erythropoietin. But in cancer surgery, there are two important considerations. One is the increased risk of thromboembolism. And the second is certain malignancies, they have erythropoietin receptors, and giving erythropoietin might actually cause.
Yeah, so this is very important to know in a cancer patient, that the erythropoietin, which we normally give in a renal transplant patient or a CKD patient to improve this hemoglobin, is not very favorable or not good for cancer patients. So that's why we normally don't give erythropoietin for anemia correction in cancer patients.
The only indication which has been told in cancer patients is when the cancer patient is on chemotherapy, it is advised to give erythropoietin.
Yes.
Can I add one more point to it, Sohan?
Yeah.
Also, if your patient is a known CKD, then it is okay to give even in cancer patients.
Yeah, so that if the CKD patients coming for a cancer surgery, maybe, but not for
I meant if they are already on it. I meant if they are already on it, then it's fine.
Then it's fine. Yeah. So I agree with you. Okay, if the patient is already on the erythropoietin, or even if they're not on the erythropoietin and their nephrologist want to start the erythropoietin, then we still can be started. So this patient was given IV iron, this ferric carboxymaltase 500 milligram, given 2 doses 1 week apart. And but the problem is that after that PREVENT study came, there's so many surgeons and they say there is no benefit of giving your IV iron, because the study says there is no mortality benefit or no benefit in terms of the blood transfusion intraoperatively. So do we still give IV iron beforehand for the cancer patient?
So this particular PREVENT trial had some concerns regarding the methodology.
Yeah.
The first most important thing in this trial is that they hadn't documented iron deficiency. So for iron deficiency, anemia, but to give iron and for it to be effective, you should have iron deficiency. What is the point of giving iron if there is no iron deficiency? So in this particular study, they hadn't documented iron deficiency. And also they have given this iron at least 10 to 42 days. That is what I remember, the gap between the surgery. So it is being found that the optimal gap is at least 4 to 6 weeks. And many of the patients in this particular trial received it just 10 to 14 days. So probably the increase in hemoglobin was not to that extent which prevented the blood transfusions. But the same study has shown that it has decreased the number of admissions in the patients in the next 6 months after the surgery. So that is a very important clinical outcome, because for whatever reason, whatever organ dysfunction or any other problem, the admissions into the hospital were decreased in patients who were treated with IV iron. And also the hemoglobin at 4 weeks and 6 months was much more in patients who received iron. So there was an editorial after this PREVENT trial which said that even though there is no benefit of giving iron in terms of avoidance of blood transfusions, because the hemoglobin at 6 months and 4 weeks is increased. And also there is an improvement in the clinical outcome, that is number of admissions into the ICU. They have suggested in that particular editorial, I don't remember, I think it is in anesthesia, analgesia.
Yeah, so actually they mentioned that the
You must.
IV iron anemic patient undergo major abdominal surgery may not prevent blood transfusion, but still contribute to objective of patient blood management.
Blood management.
There are a lot of other like this letter to editor in against this study, this prevent study, and few studies also they say because of they didn't do this iron study before that. So it is advisable to do the iron study. Like in our hospital, we do iron studies and then we treat anemia according to that. So iron study before giving IV iron is also a good choice.
Yes,
right,
sir.
Vandana? Can I talk to Vandana there? Just a comment, just one.
Yes.
Yeah. So, Dr. Nishkarsh, what do you do in your institute?
So, in addition, before this, in this study, so the cutoff for anemia was 12 and 13 respectively, which is not an anemia for us if we talk about that. So maybe less than 8, 7. So that will be the things which will be worried for. So in our hospital, depends on the patient's condition and the type of anemia and the malignancy the patient is being operated for. As a policy, we do not do a preoperative blood transfusion to these patients. Mostly these patients are chronically anemic and well compensated for the anemia per se. If feasible, we do a preoperative total intravenous iron therapy. The reason being that oral iron therapy, mostly anemic patient will be mostly in a GI malignancy, specifically colon cancers.
So they will know much like absorb.
Oral will not be absorbed, will not be tolerated. So it doesn't serve the purpose mostly. So we do go for a preoperative intravenous iron. And it is very well tolerated, especially nowadays the available IV iron is very well tolerated and reactions are much less. And we are very sure that the iron is going into the patient. And we do get document that it is because of iron deficiency. Then only we give iron because, and mostly it is, but still we document for practical purposes. We do get total iron binding capacity, ferritin and other values. And once it is documented, we give them, and within 2 weeks, it does help in improving the overall anemia of the patient. And we do arrange enough packed RBCs because they may be needed during and after the surgery.
Yes, sir, that is the need. Okay, so we quickly go because we have a very less time. So like for the comorbidity management, so the anemia part is done. The comorbidity management, so we advise with the dobutamine stress test in high risk joint clinic. When that was negative for intestinal ischemia, we like did this hypertensive management, like the blood pressure was okay with the 2 tablets, and then diabetes were also fairly controlled with the HB1AC was around 7, and the asthma was also because they no exhibition in the recent time. So comorbidity management was fairly good for this patient. About the nutritional pre-application, I want to say, because the patient having albumin of 2.6 and globulin of 4.2, so it's a big AG reversal and a low albumin. So what is your nutritional optimization goal, Dr. Nishkarsh?
So yes, Dr. Sohan, in this patient, we know that the BMI was 17, albumin was on the lower side, the AG ratio was reversed. So we knew this patient is having a poor nutritional status because of the malignancy, because of other reasons, whatever might be there. And it is important to improve the nutritional status of the patient. So what we do is we try to follow simple scores like a PONS assessment tool, which is like a tool. So we check for BMI, we check for unplanned weight loss, more than 10% in past 6 months. And we ask the patient whether he's eating less than 50%, less than what he used to eat most of the times. So if one of the answers is less, so in this patient, the 2 of them are positive. So then, and in addition, albumin is less than 3. then we send the patient to a dietitian. So we do a dietary chart being prepared depending on.
So which tool you will go if you want to use one tool, which tool you will go for the assessment of the nutrition in this patient?
So we use this.
So we have around 4, 5, 6 tools, right, to assess the nutrition.
Global assessment is there. We have other tools also. PONS I found very practical. So it is a recent tool which is there. It was in anesthesia analgesia. So basically it focuses on BMI, weight loss, and the overall appetite of the patient in addition to albumin. So combination of this gives us a good insight, and it is easy to do without much any gadgets in the setup.
Okay, Dr. Reshma, which tool you will go for this patient?
So we use the SDA tool. So
yeah,
that's what we follow. But
Okay.
mainly we don't, we refer to the nutritionist from the beginning. I think the surgeons at the time of decision for surgery itself, the referral is made for all the patients posted for HPV surgeries.
Jyoti, do you send your patients for this nutritional assessment like from PSC or before PSC, or does the surgeons send?
Yeah, sir. Actually, we have recently appointed a dietitian, not on a regular appointment as such. So, since the time she has joined, we are sending our patients to the dietitians. However, approximately 1 month back, we did not have that provision in our hospital. So nowadays, we are making a policy to send all such patients to the dietitian.
Okay. So, and Dr. Nishkarsh, what is your goal like, and what intervention you will do? You will go for the oral, you go for the enteral, or go for the parenteral nutrition in the pre-op period?
So
And what is your goal for this nutrition intervention?
Reduce the catabolic state in the patient, try to improve overall nutritional status. We prefer an oral oblique enteral depending on the feasibility. Parenteral we usually do not consider for these patients. Orally, sometimes considering GI malignancy, they may not be able to tolerate whatever nutrition is being advised by dietitian. So we do get a rice tube oblique peg depending on the situation, and to improve the overall nutritional status of the patient.
Okay. So you will go for the oral or SOS enteral nutrition. And if anything like not possible oral enteral, then like in the last surgery, we can go for the parenteral.
It is very rare.
Mostly not needed, yeah.
Mostly not needed.
So the goal of this nutritional assessment is not really a weight gain, but rather the replacement of energy, protein, micronutrient, and the glycogen store. So complete package should be there for the patient for an overall increase in the health and the nutrition status of the patient before going for the surgery. So for that, we give around 1.2 to 2 grams per kg per day of the protein. Okay. So do you have any albumin goal now? Like now this patient is having albumin of 2.6 or 2.7. So what is your goal of albumin? Like how much, at what albumin level you will take this patient for surgery?
So if we go by the book, so less than 3 is not good, but whatever we may do, albumin may not increase. So and whatever intervention we may do, considering the limited time, 2 to 3 weeks, albumin levels don't come beyond 3 gram mostly. But any start of increase in albumin levels is a good indicator. And in addition, overall catabolic state is also improved. So both the ways the patient is improving, and there is no specific role of giving albumin per se for improving the albumin of the patient. So that is.
Yeah, so actually this albumin, because it is an independent predictors of the post-operative mortality told by many studies, and the many studies also they're showing that the albumin of, if not 3, at least 2.8 plus it should be there to go for surgery. But 2.8 is still having high risk, but the 3 will be better. More than 3 is better. Still 2.8 should be a cutoff to take for a major abdominal surgery like liver or like this people surgery. But still, after if we are doing a good optimization, 1 month optimization, 1.5 month optimization, if not albumin is not coming up, in that way we have to take the risk and take the patient. But it is always better to optimize the albumin level of at least 2.8 or 3, depending on the patient response. So this patient was advised around 4 to 6 eggs per day, and have a high this protein supplementation diet also started. Okay. About this pulmonary and physical rehabilitation, so how will you plan, how will you time, what education you will give? Dr. Reshma, please.
Yeah, so on this patient definitely needs pulmonary as well as exercise prehab. The only this is that we have 2 to 3 weeks. I mean, it is shown that it at least takes a minimum 3 weeks to show any improvement. 3 to 6 weeks is the ideal time which is required. But moment the surgeon has decided that the patient should and dates for surgery, we should refer to our physiotherapist, and the prescription for a patient is for that very patient. So it is not one prescription which fits all. And so the our physiotherapists work on each patient by assessing them. So in this case, there'll be 2 prescriptions. One would be for the respiratory exercises, and the second would be for improving the aerobic capacity, that is a functional capacity. So for pulmonary per se, they have deep breathing and coughing exercises, and the breathing exercises are augmented by devices. What we use is incentive spirometry. So that is decided according to the gender and the height and weight of the patient. And also now, though we are not really following, but there is evidence of inspiratory muscle training, which is targeting specific muscles responsible for inspiration. So there are 2 types what could be done. The inspiratory muscle training is not what we are regularly following at TMH. The other, this is the exercises definitely to improve the aerobic capacity. Now, this patient has multiple comorbidities, has a low BMI, is nutritionally very susceptible for postoperative pulmonary complications. So improving his lean body mass to fat ratio as well as the aerobic capacity would improve his postoperative outcome. So the prescription will be mainly aerobic, muscle strengthening, and also flexibility exercise. As I've already said, this patient is pretty frail, so I don't think high intensity would help. Now, high intensity or moderate intensity is decided by seeing what the this is on the BOD scale, what we use. But in this patient, I think the moderate intensity exercise would be what the physiotherapist would start off with. And that would be at least 5 sessions per week. And also the other exercises will be the muscle strengthening or resistance exercises and the flexibility. So at TMH, we are using the TheraBands, and those TheraBands also have different resistance. So we, in this case, the physiotherapist would decide what the patient can do, and then give him the TheraBand which is most suited for him. And then according to his progress over the next week or 2, now in this case we have only 2 weeks, otherwise if we have 4 weeks, we kind of look at 2 weeks and then increase the resistance to TheraBands, go one up. And also for the intensity exercises, we kind of start off with just walking, or simple walking, or biking, or 3 to 5 times per week, and then increase according to what the patient can do. So in this case, I think we'll have to go very slowly with maybe 20 minutes of really exercises with 5 minutes of warm up and 5 minutes of cool down. See how the patient goes through it, and then kind of increase at 1 week, because we just have 2 to 3 weeks, and see and go up. So yeah.
Okay. So the main thing is that we have to educate the patient how he should do the exercise. So the proper training by physiotherapy is must for the good outcome. And
Yeah, so also definitely that is, and also whether the patient is staying where the hospital is, so whether it is home based or whether the patient can come every day to the hospital is very important. So supervised is, the compliance is definitely higher, but it's not very convenient for most patients, whereas if it is home based, it is more convenient for patient, but then there is a need for
compliance is not
follow up
really good.
on the follow up with the patients on the phone is required to keep a check on the compliance. So both are required.
Okay. So you talk on this, you already talk on this role of high intensity exercise, because he's frail, he cannot do really high intensity exercise. And role of CPET also we discussed one. So this patient was started incentive spirometry 2 weeks prior to surgery, and he was encouraged to walk at least 30 minutes daily on a plain surface, because he was frail, cannot do much exercise. So he was advised to walk at least half an hour per day. Okay. So after 3 weeks, his hemoglobin is still 8.9. He's not, because of IV iron, we given 2 doses, everything. So, and albumin increased to 3.2 by the high protein diet. Albumin, this globulin also came down from 4.2 to 3.8. Still, there is just some AG reversal, but should be okay. Creatinine is same 1.3. And upper tolerance definitely improved from 1 floor to 2 floor, and we verified, because we sent one resident with the patient to climb 2 floors. So I think there is this improvement in nutritional and the physical part, but not in the anemia correction. And so this patient, because now we cannot do more anemia management, this patient was taken for surgery after 3 weeks. Okay. So will you go for the GA with epidural or without epidural in this patient, Dr. Jyoti?
Yeah, sir. Yes, sir. I would prefer GA with epidural, because as such there is no contraindication to epidural in this case, and good post-operative. First of all, sir, for the intraoperative hemodynamic parameters, the patient is already hypertensive, and we need to minimize the intraoperative hemodynamic variations, like episodes of hypotension or hypertension, and that will be hemodynamics will be better maintained with an intraoperative ongoing epidural. Next thing is that post-operative, we need to give a good pain relief to this patient, so to decrease the post-operative complications, and epidural will be a good choice for the initial 2 or 3 days at least. The pain relief will be good for that.
Okay. So Dr. Nishkarsh, what advanced monitoring you will go for this surgery?
So,
like apart from your NIBP, pulse oximetry, ECG, what advanced monitoring go?
So minimum I'll get a central venous CVP catheter in, maybe IJV or sub-11 depending on feasibility, and an arterial line. Considering the patient had a poor LV function, hypertensive, diabetic, it may be a good idea to have an arterial line in situ before induction of anesthesia, so that you can have a bit-to-bit blood pressure monitoring, and you can better titrate the anesthetic drugs.
So regarding CVP monitoring, Dr. Indira, are you agree with the CVP monitoring? Because many patients, like doctors or institute, they want to go away from CVP monitoring. Although we can use this central line for giving inotrope vasopressors, but CVP monitoring is really needed or not, Dr. Indira?
Actually, now people are moving away from the static indices, and we usually monitor the systolic pressure variation. Most of our monitors have systolic pressure variation, and some monitors have a PVI also, plethysmographic. But then with an arterial line in place, SPV is a very good indicator of the volume status, much better than CVP, sir. So apart from the CVP, as you said, the indication is vasopressors and probably sampling, etc., in the post-operative period. But for monitoring of volume status, more dynamic indices like systolic pressure variation, which are now available with most anesthesia workstations, I would prefer that. And we do use SPV and pulse pressure.
Yeah, so I also agree, because we should put the central line, but because this patient may require vasopressors intraop or like inotropes or whatever. But regarding CEP, Dr. Nishkarsh, I still have some doubt, because the I don't know really that what CEP we will.
You are right. So CVP central line is put. I specifically mentioned central line, not CVP.
Okay.
So we put in central line
Yeah,
for
so that our that message should be that central line for vasopressors, inotrop, not really possible. But if we want to measure CVP, we can measure, but not for monitoring purpose, right?
Yes.
Okay.
And in addition, if possible, if you have a cardiac output monitor, Vigilo, then it is a good idea to start.
So if you have a more advanced monitoring, if you have a like HPI monitoring or a flow track monitoring, that is still better. But many centers may not have this. But still, at least an arterial line and a central line is required in this type of patient. Yeah. So what MAP goals you will have? Even arterial line. So what MAP this patient was having is 168 by 92. So MAP will be around 120 pre-op in the PSC. So what MAP goals you will target intraoperatively in this patient?
Within 20% of whatever the patient was set for baseline. So if it is 120 baseline, mean arterial, so it should be within say around 100 should be my target, 95 to 100.
And what if the surgeon is saying we are having bleeding and patient is having, because we are keeping high MAP, patient is bleeding and all these things.
So, and I don't think the surgeons really complain about MAP.
I'm just because
and I think if you tell them that this is what the studies have come up with to prevent, so we have to maintain the MAP for between 10 to 20%. I don't think we really have the problem at our institute.
Okay. So MAP goal straightforward will keep.
We can always give
plus minus 20%, right? Yeah.
Yes. We can always say we are giving something to reduce blood pressure and keep them happy and still.
Because we have to keep happy the other side of the grape also.
That is true.
And fluid therapy. So fluid, like what fluid you want to give? You want to give like which crystalloid, which colloid is real, what monitoring about, how will you go, goal directed, liberal, restrictive, and what is your blood transfusion trigger, Dr. Reshma? All these things, please, in short, please.
So goal directed, transfusion trigger, we are starting off with 8.9, so I think I will keep that at least. And so goal directed is this, and we use crystalloid to start off with balance. We are using ringer lactate, and and in this case, obviously, PPPD with portal vein, you expect blood loss. So I would keep adequate blood ready and to replace the blood with whatever losses we come across during the surgery.
Okay, so which goal? What goal, Mala? It is your PPV, your SPV, your lactate?
Yeah, so we are using PPV only. So
PPV. So like if you're having cardiac monitoring, you can use SVV. If you want on your arterial line, you can use PPV. If they have, you can also use the SPV. If they have an ABG, you can use lactate. So all these goals people can use. So now the introp issues. So during portal vein resection any concern, Dr. Nishkarsh? When they clamp the portal vein, do you have any concern?
So basically, we are worried about the ischemic time when we are being done. So depending what method they're using for clamping, so we have to be careful. We should time it, and we should appraise the surgeon of what time has lost and how much they have time left for doing it further. So it is really important, and we should be really on toes when this clamping of the portal vein is being done in these patients.
So, like, do you want to give like some vasopressors or some high fluid or some blood during?
So I'll prefer to give more vasopressors than fluid during this time, because you have to maintain the mean arterial pressure and don't want the pressure at overall higher because of the fluid, because it may be tricky to give more fluid at this moment. So, okay,
Dr. Indira, if this patient is started with a hemoglobin of 8.9 and now we bled around 2 liter, how will you manage the blood in this patient?
Sir, I would actually keep a transfusion trigger of around 8. So I'm actually having a leverage of 1 gram. So my allowable blood loss would be around 500 or so. But beyond that, I feel that because of the comorbidities and other things, I would replace blood with blood, because giving crystalloids further will cause hemodilution, the dilutional coagulopathy. Excess of crystalloids, especially with the portal vein clamping, will cause bowel edema. Later on, the issues of leaks from the bowel, all these things will be aggravated with large crystalloid transfusions. So apart from allowing around 500 ml blood loss, which is what I will think as maximum allowable blood loss in this patient, any other bleeding I would like to replace with blood, because we are starting with a low hemoglobin and we do not want to give too much crystalloid.
Okay. So, Dr. Reshma, role of albumin as a colloid intraoperatively. Do you really think that we should give colloid albumin as a colloid, or we can just give as a diluted albumin, undiluted albumin, and 20% or 5%? What is your take on, or 4%?
So currently, we are only using crystalloid Sohan, and we are not using albumin in 20% form. We do use, if there is after the blood loss is taken care of, and then to maintain the colloid osmotic pressure, albumin could be used, but not when there is ongoing blood loss. In case we can get away with crystalloids, and in this case, obviously the hemoglobin is 8.9, so the patient will be needing blood. As what Indira said, she is happy with the target of 8. I will not even let it drop to 8. I think because it's anyway, if there is an ongoing blood loss, we will have to transfuse early, and 2 liters will be a bit too much for this patient. So yeah, only after everything is this, I would use albumin.
So can I add in that? I mean, there are some recent studies where they've actually used both 5% and 20% albumin as colloids, especially in the bleeding phase. And they have found it to be actually useful in volume expansion. And but as you have said, if there is an ongoing loss, albumin should be given along with crystalloids, because otherwise it causes dehydration because of the
So there's one thing I want to say: if there is an ongoing blood loss, we mostly should not wait for the MBL to reach, because we don't want that decompensation part to start. So if there is an ongoing blood loss and we expect a major blood loss, I think we can start with the blood management early rather than reaching the MBL, right?
I agree, Sohan. Also, probably in this particular patient with diabetes, hypertension, and possible CKD, my MABL in any case would be 0. So we are starting with 9, and I don't want to go below. Well, ideally, we should be around 10 in these patients. So
but there is no 10 before starting.
so no 10. So we are taking up. So in any blood is placed with blood in this patient.
Yeah, I agree, Nishkarsh. I mean,
I disagree, because one thing is, even after optimization, the symptoms improved and the vitamin stress was normal. And even a single blood transfusion if avoided, because it is actually cumulative. The more number of blood transfusions, the more is the cancer recurrence, though it's still in investigative stage. But probably avoid in a single blood.
Dr. Indira, I agree with your comment, Days, but the main thing is that the cancer recurrence part will come very later on, and he's already a 70-year-old gentleman with a frail gentleman, so many comorbidity. So I think that we can start blood early. We should not be thinking about cancer recurrence at this stage when we are really managing a bad patient intraoperatively. What do you think?
Can I just say something that the webinar was actually where we took off as a hepatic patient coming for a non-hepatic surgery. So we must remember that their targets are much lower, and if we let these guys bleed ischemic hepatitis, and pushing them into liver failure is very high. So we have to be on top of things here.
Yeah. So okay, so we are already running very late actually, and
we are going to
ask one last question only. So this patient is because they took a long time to reconstruct the portal vein after the resection. It took around 45 to 50 minutes. Clamping was there, and there was a high lactate. Would you like to extubate this patient at end of surgery, or want to give a elective ventilation, Dr. Reshma?
So if at all the patient, not only the portal vein clamping time was more, lactate also rising. How bad is the? Is the patient needing vasopressors?
No, that vasopressors is a very low dose, around 2 ml or 3 ml. Well, is a very low dose, 0.05, something like that, or less than that maybe. So, patient on a low dose of the noradrenaline with high lactate and a high.
And how high is the lactate?
So
and the lactates are going to take how much?
Initial starting lactate just after induction was around 1.8, and now it is 6.
6. And also, the lactates are going to take time to clear.
Yes.
But if hemodynamically patient is stable, I'm sure of the epidural being in and working well. And rest of the parameters, I've got hold of all the fluids status is okay. Can give a trial for extubation, but also should have a low threshold that in case the patient is to at least then, if at all not for extubation, then can be shifted on CPAP pressure support. So lactates cannot be the only this. If the rest of the ABG have got the hemoglobin is, at least a target of 8.5 plus.
But there was a 2 liter blood loss in a patient.
Yeah, but then I would have transfused, right? 2 liters.
Yeah. Low dose noradrenaline, longer duration of portal vein clamping, and lactate rise. So.
And if the surgeons are happy with the portal vein, the resection and their reconstruction, 2 liters is not very huge.
But it would be huge for a patient with a hemoglobin of 9, right?
But if you have transfused enough, trial can be given. Lactates cannot be the only.
Can I add?
Please add.
I would like to ventilate because I would like to see further trend. And here there is a portal vein reconstruction just happened. So I would like to see the trend. If it is not just the ischemia or rather the hypoperfusion, we also need to know the integrity of the portal vein, which was reconstructed, whether there's any portal vein thrombosis acutely, which is actually leading to further rise. So probably a Doppler or ultrasound. And then if that is ruled out, then just observe the trend of the lactates and then extubate.
Well, I'll agree with Indira ma'am. So when in doubt, better to delay extubation. So this is my simple dictum. So there's no harm in, because usually it will take about 6 to 8 hours. You are already in the late evening or depending on what time you started and patient's lactate rising. I'll prefer, me and surgeon will prefer to have a good sleep as well as the patient, and probably extubate the next day when things are settling down.
Okay, so now I will give it. So this patient can be given a trial of elective ventilation, or if you want to extubate, you can just extubate and see the patient for some time in the OT, or you may re-intubate also. That depend on the patient at that time of the surgery. So I think we are done with this panel discussion, and it's really good to see some contradictory statement from the different panelists to have a good discussion. So I really thank Dr. Reshma, Dr. Nishkarsh, Dr. Indira, and Dr. Jyoti for a good discussion, and ICA for this opportunity. Thank you very much. And
thank you, sir, for inviting us. And thank you, ICA, for this opportunity.
Thank you, Sohan.
Thank you, everyone.
And I must admit, it is not a rehearsed panel, so it is our extempo panel, and panel should be like this, because then you get the real answers. Otherwise, everything is
I think Nishkarsh, I guess we are all anesthetizing these kinds of patients, and it just brings out various ways of how we are dealing with our patients. So I think it's a good learning experience for everyone.
Dr. Sanish, we can conclude now. Thank you.
Hello. Good evening, friends.
Good evening, sir.
Well, it was so interesting. I think we all lost track of time. And I must thank you, Dr. Solanki, first of all, for very nicely moderating the whole academic session. Earlier, the lectures, and then thereafter a case presentation, which I think brought out, opinions from each of the experts. So first 3 lectures, wonderful lectures, starting with Dr. Mitra on the role of prehabilitation. I think it's more and more, being practiced in Indian hospitals. Earlier, the concept wasn't there. She spoke on rehabilitation and how it improves functional ability of the patient. And then Dr. Nishkarsh Gupta on physiological and pharmacological optimization, how it is done and what benefits it brings to the patient in the long run. And Dr. Jyoti Sharma, I think she was brought in at the last moment, but she did a great job with the perioperative management of the patients with liver disease. I also would like to take the opportunity to thank 2 people. One is Dr. Kumar Belani from US. It must be very early morning for him to join this, and apart from that, he gave a valuable input on the role of anesthesiologists in the surgical concept. I don't think it's there in India. Maybe some of the hospitals I may not be aware, but this seems to be a very interesting concept, and I'm sure in the years to come, this will be there in Indian hospitals as well. And the second to Dr. Vandana Agarwal, despite the health issues, she was still there. Thank you so much. Special thanks to both of them. And thereafter, Dr. Solanki, you had a case presentation wherein, all the speakers, whether it's Dr. Lalita Gauri or Dr. Indira Gurajala and Dr. Reshma Ambulkar, as well as Dr. Nishkarsh contributed. It was so pleasant a discussion, even though there were differences, but everybody backed scientific evidence that yes, this is how it should be done. I'm so happy that this webinar went so smoothly and brought out the best in each of the speakers. Thank you so much, friends. We are already very late. It's time to call. And on behalf of Indian anesthesiologists, I thank each one of you for giving your best to this webinar. Till we meet again next Wednesday. Thank you so much, and good night to everyone.
Thank you, sir.
Good night.
Thank you, sir.
Good night.
Thank you, sir.
Thank you very much.
Good night.
Good night.
Thank you everyone for sharing your valuable insights. We are more than grateful to everyone present here, sir and ma'am. We hope to have you again on our platform very soon for your next session. With all your permission, we are closing the room.
Thanks, Leonard.
Thank you,
Thanks.
Indira, and good night.
Thank you. Thank you.
I missed out. Sorry for that. Good night.